call the meeting to order and want to welcome our presenters. And we have a challenge this morning in that we think there's going to be a vote around 10:30 or 10:40. But and then the members will have to leave to go vote. And depending on the time, we'll either come back or not come back. But we'll do the best we can to make sure we hear from you. And I know that we've asked you to make a 10-minute presentation in the opening, but if it's possible to tighten that up a little bit, it gives us more chance to ask questions because of the restricted timeline we're going to have today. But anyway, I certainly welcome all the presenters, and I know we're going to hear some interesting testimony. So we're going to start this morning with Chief Isidore Day, the Ontario Regional Chief. So Chief Day, if you would proceed and make your opening presentation.
Thank you, sir. And I'd first of all like to acknowledge that we are on the unceded territory of the Algonquin people, and I'd like to acknowledge the Creator, creation, the prayers, and the protocols. Today I will accommodate the time pressures. However, Mr. Chair, I do want to make an initial note that, these are long-standing issues in our First Nation communities throughout all regions across this country, and those that are suffering from this affliction of opiate addiction are living within a prison of physical and psychological torture from this addiction, and I think we need to ensure that we afford the time necessary. So I will, however, accommodate that there are time pressures within this House today, and I will ensure that I afford time for my colleagues that are also presenting. So I'm presenting here as the Ontario Regional Chief, as a member of the AFN Executive who holds a portfolio for health, and the Chair of the Chiefs Committee on Health at the Assembly of First Nations. So in fact, I represent 633 First Nation health issues across the country. I'm here because the opiate crisis occurring in Canada is also a crisis that is occurring in many of our First Nation communities. Prescription drug abuse is increasingly exponentially, and communities are overwhelmed with incidents of illicit drug abuse. The use and abuse of substances has consistently been a top priority for First Nations people as well as its leadership. In fact, a national survey of First Nation communities completed between 2008 and 2010 reported that alcohol and drug use and abuse was considered to be the #1 challenge for our community wellnesses faced by on-reserve communities at 82%, followed by housing at 70% and employment 65%. Prescription drug abuse is exacerbated by widespread violence, endemic poverty, emotional abuse, and lasting intergenerational traumas of colonization. The psychological and social effects of residential schools has also contributed enormously to the level of addiction in First Nation communities, impacting people of all ages, and First Nation youth are especially vulnerable to the effects of substance abuse. The question then becomes, what can be done? More action is needed, and that's what we're here to address today. The decolonization of the healthcare system in order to reduce prescription drug abuse in First Nation communities is essential. It is imperative to fully implement the First Nations mental wellness continuum framework. The framework outlines opportunities to build on community strengths and control of resources in order to improve existing mental wellness programming for First Nation communities. This includes community development, ownership and capacity building, quality care system and competent service delivery, collaboration with partners, and enhanced flexible funding. And ensuring culture is at the center of mental wellness and must be understood as an important social determinant of health. So again, we do have the work. The continuum has been a culmination of years' work, Mr. Chair, and we do have a leave document here for the committee members. Full implementation means increasing the amount and flexibility of resources in order to increase capacity, ensure quality care systems and competent delivery so that all First Nations have access to essential basket of services that make up the continuum of care. A full and adequately funded continuum of services also includes long-term funding for community-based prescription drug abuse programs such as opioid substitution therapy with buprenorphine, along with land-based treatment and other cultural treatments. And again, I just want to note, Mr. Chair and the committee members, that we are probably experts in the experience of alternative use to opiates in our communities. But the one thing I must underscore is that what we're finding in a lot of our remote communities is the fact that they don't have the amount of services that other regions do. So in remote and rural territories in other parts of Canada, there simply is not enough resources. So what's happening is you're almost getting to the point of solution with the alternatives to opiates, but there's no follow-up, there's no investments being made, and that really is throwing good money after bad. And it's actually perpetuating, the ongoing and torturous cycle of addiction. Because what happens is, if there's no aftercare, if there's no completion of that continuum of care, aftercare, then you're actually not getting the results you need, and it's actually complicating issues. So one of the things that we're looking at, Mr. Chair, is that we definitely need to look at the opiate addiction from, if you think about what they do in a crisis situation, from a medical perspective, they triage that situation and they look at all aspects, the environment, the situation, the injury, and in this case, addiction being the injury, having to fully address in a very specific way that is meaningful at that community level. In the north, there's a very different situation happening, and we do need results-based investments, and that investment spending has to include land-based programming. It has to include aftercare for those communities in the north. The mental wellness continuum framework, the creation of a community-centered and culturally driven health promotion framework is essential for building effective alternatives to the current treatment system. Ideally, a new system would enable First Nations to integrate their values, beliefs, and ways of knowing into programming, making a culture a foundation of health care and promotion. It is a plan that provides a broad framework and allows communities to build programs and services based on their unique needs and responsive to service gaps that exist. What I'd like to do, Mr. Chair, I generally like to complete my presentations, but I do have Carol Hopkins from the Thunderbird Foundation, who is an expert in the field and somebody that we rely on in First Nations across the country, and I'd like to afford her a few minutes of my time to provide some remarks as well. Thank you.
2 minutes.
Thank you so much, Chief.
Welcome.
Good morning. My apologies for being late this morning. I'm Carol Hopkins, Executive Director of the Thunderbird Partnership Foundation. Our mandate is actually to implement the Mental Wellness Continuum Framework and the Honoring Our Strengths Renewal Framework. And our focus is in mental wellness, meaning addictions and mental health. I want to also begin acknowledging the invitation and say thank you for that, for sharing the time with the Assembly of First Nations, and wanting to recognize the Algonquin people whose land we are meeting on today. I'd like to start off by taking us back to 2004, when the third report from the Auditor General criticized First Nations and Inuit Health of Health Canada for the third time for not doing enough to mitigate the issues related to prescription drug abuse in First Nations and Inuit communities. Then First Nations Inuit Health established a drug utilization, prevention, and promotion working group. And that working group had a mandate to do three things. One was to make data more available from the non-insured health benefits. Second was to provide, engage First Nations communities in developing and implementing a community-driven response to prescription drug abuse. And the third one was to work with prescribers to address practices and situations with overprescribing. So that was in 2004. We're 12 years later, and one of those issues is still outstanding, and that is the pilot and proposal-driven nature of funding to First Nations communities to address prescription drug use issues. That's the most critical issue when we talk about the opiate crisis amongst First Nations people, is that it's annual funding based on proposals, and that those proposals are not always fulfilled, and it's year-to-year funding, somehow expecting that within a year we're going to be able to take care of the opiate crisis that exists in First Nations communities. So addressing the opiate crisis has been a challenge then, most significantly because of the inconsistent support to community-governed and culturally based treatment. One community-based opioid study misuse report reported that among adults ages 20 to 30 years old, 26% of the community was engaged in a buprenorphine naloxone program. Now, that's 28%. 28% of the community is double the rate of diabetes in that same community. So we have dedicated funding, thankfully, to address the issues related to diabetes in our communities. But we don't have the same type of resources when it comes to dealing with opiate crisis. The Drug Utilization Prevention Promotion Program was successful in demonstrating piloting a number of community-based programs. We also have a Lakehead study that demonstrated the success of community-governed programs to address opiate addictions. We have other programs in Northern Ontario that you'll hear more about, who also demonstrate the importance and significance of their success, unfounded in urban environments and other communities, simply because of the team-based, community-driven, culturally based programs that are offered, and yet they do not have annualized committed core funding within their health envelopes.
Ms. Hopkins, I have to call.
That was the main point I wanted to make, so
I'm
thank you very much, Chair.
Thanks very much. Okay, Dr. Chase.
Thank you for this opportunity, and I'm very much hoping that this will be a meaningful consultation and not further history made with consultation that doesn't lead to action, because it is not extreme to say that there are lives at risk on a daily basis because of the opioid crisis. I'm speaking to you today about what I'm most familiar with, which is how the crisis has impacted Northwestern Ontario First Nations. I work with a practice that serves remote First Nations, and we were the first, I believe, in the country to start community-based treatment programs in partnership with the First Nations who wanted help. I want to make 3 key points today. The first is that the communities have worked with their primary care providers to build locally run community-based treatment programs. These are grassroots, they're innovative, and they are effective. Effective if you measure them in terms of children coming back to their parents, people being able to return to work and education. They provide a model that could be offered to Indigenous people across Canada, and I say offered, not imposed upon. There are ongoing challenges, and I'll get to those, but I want to go through the key points first to make sure I have time for them. Health Canada's response to this crisis can be measured along a continuum, with the low point being obstructionist and the high point being woefully inadequate. The nurses have been forbidden to work with clients in the addiction program for more than 30 days. And if any of you know anything about chronic illnesses, we don't fix diabetes in 30 days, we don't fix addiction in 30 days. And there's abundant scientific evidence to prove that this is a chronic illness. And again, I'll speak to why this is problematic later. And number 3, a key point, I think disrupting, and our Prime Minister has used the theory of disruption as a positive force, and I believe that. Disrupting the status quo of archaic colonial policies and embracing self-determination for First Nations is key to ending intergenerational trauma. And I think what this could look like is supporting people to develop the community healing strategies that they believe will work. And that means long-term support. It may also mean funding evaluation so that there is accountability. But I believe that's key. I want to go back to the first point about the treatment programs and what the challenges are. And the ongoing challenges include the lack of stable or adequate funding, little access to land-based treatment. The fuel prices are insane on reserve. So we've seen over and over that when communities can commit to these programs, clients get better. But when they come back, especially because they're only short-term time on the land, the relapse rate is high. So I think that's something very concrete that you could offer to support that the communities have asked for a long time. There's no real addiction training or treatment of vicarious trauma for frontline staff. And I tear up every time I think about this, because our workers are putting themselves in the line to hear the stories of incredible trauma. We have little funding to train them. These are community members who, because Health Canada has refused to step up, they have stepped up, and they do this and they get traumatized daily, and I have little or no means to support them other than being their family doctor. It's not acceptable. My sister worked at an Ottawa clinic for street-involved people. The training she had was unbelievable to work at Oasis, to deal with this on a daily basis. The debriefing was phenomenal, and she was able to do it for 16 years. I don't think the workers are going to last 16 years. I can elaborate more on Health Canada. I told you that there's an actual policy. You can check with the FNIB nursing branch about what they've directed nurses to do. And I'm sorry I didn't bring that document, but it's been circulated. They can help no more than 21 patients and for no more than 30 days. So what's happened, and I hesitate to even bring this up, but lay people are now storing and administering and counting buprenorphine naloxone, which is a very powerful opiate that we use to treat narcotic addiction. And they're doing a fantastic job, but it's not acceptable. I was a nurse before I was a doctor. We had so much training on how to be accountable around narcotics. And yet, I mean, these community members are doing it. I don't want to undermine them, but it's not fair. It's not a service that would be provided down here, or a lack of service, I guess. And it's creating a divide between the communities and the nursing station, and that the communities say this is their most urgent concern, and the nurses are being told by FNIB that they are not to be involved in this. And it creates it creates conflict at the local level. For the last point, the embracing self-determination, I've included the article by Chandler and his colleagues, and I'm sorry, it will be translated, it hasn't been yet. He speaks very strongly to what was a protective factor against suicide in Aboriginal communities in British Columbia. And he said the protective factors, the communities that had lower than the dominant culture suicide rates, it wasn't based on economics, it was based on self-determination and attachment to their culture. And so those are concrete things that you have the opportunity to support and save lives. And I have a story, it's a client, and it's an all too familiar story for us, of a woman who started snorting Percocets because she had been sexually abused as a child and then also abused as an adult. And her marriage fell apart. She went from Percocets to oxys, snorting to injecting, luckily escaped hepatitis C, which many of the people in the community I serve have contracted. Her marriage fell apart, and 3 of her 5 kids went into care. She joined our program in 2011. Her husband joined 6 months later. To be honest, I thought she could never make it from what I had seen. And then one day her husband said to me, I'm getting better. I've got back with my wife. She's really strong. And I said, who's your wife? And he mentioned this woman who I had presumed would not make it. And she has proven her strength. She's got all her children back. Her marriage is back together. Both she and her husband are working. But her children have multiple needs, including the trauma that they suffered when they were apart from their parents. I have no access for family therapy for them. The children need testing. I have no access to get them tested. Again, this is not acceptable care. My colleague, Dr. Mike Curlew, presented on the lack of services to children and isolated reserves. These are concrete things you can change. Thank you very much for your attention.
Thank you very much for your firsthand testimony and your experience. So our next guest is Dr. Al Gabali, Professor at the Department of Psychiatry at the University of Calgary.
Thank you very much for the invitation and the experience. It's my first time standing in front of one of your committees. First of all, may I support all the statements that have been made. And I was thinking, listening to my colleagues here, that there's a fair amount of consensus of what we're talking about. I think the issues and so forth. And I'm saying, if there's so much consensus, how come we're still having so much difficulties delivering the services we need? I wanted to support, in particular, to put things in perspective. I've been in the field 48 years, too long, I think, as an addiction physician and addiction psychiatrist. And I want to put in perspective that when we talk about drugs, we should never forget about alcohol and tobacco first, followed by the other drugs. I think we all agree that the problem we are facing is a bio, psycho, socio-spiritual problem. I think there is a lot of agreement on that, certainly among the physicians who specialize in the field. That's a common agreement. This is not only of having one or the other, it's all together. This is the package. Now, I couldn't help also but thinking that probably 10 years ago, I would have been here talking about methamphetamine. Before that, I would have been talking about stimulants. Before that, I was talking about heroin. So the field has a way to bring continuous crises, one after the other and another. I would assume that one of the reasons why we're meeting here is that at this point in time, hundreds of our patients in Western Canada are dying from the fentanyl crisis, and also the overdoses from prescription. And I like to tell people, unfortunately, we also should plan for the next crisis. We already have it. The next crisis is not fentanyl. The next crisis is carfentanil, 100 times more potent than fentanyl. Who else is coming up? What is the major difference occurring right now? Major difference in the past that our addictive drugs used to come from plants. This is now a thing of the past. Our major drugs will now come from labs. Therefore, the frequency, the potency, and all those qualities is going to change much more rapidly than it used to before. And that's, I think, is a new phenomenon, I think, that we should be careful of. Now, I'm a strong believer, and I've got, the few minutes, a strong believer that a crisis is also an opportunity. And when I look at what has been happening over the last while, I just want to point out some topics, I think, that may give us, I think, some hope. The crisis at the moment has three components to it. Number one, a component of overdoses. This is what makes people die. Hundreds of people have died. It's been actually, in terms of lethality, it's been many years since I've seen such amount of people dying so fast. They're not all addicted. There could be my son or my daughter going to a rock band, to a rock concert, and taking those blue pills, and sometimes they don't even know what they're taking, and before you know it, respiratory depression occurs, onto emergency, and you're lucky when you pass on. These are not addicts. These are experimenters. So overdose. Out of the overdose, we are now providing more and more across the population is naloxone injections. And I want to congratulate Health Canada. Not very often I congratulate Health Canada, so let's congratulate Health Canada when it's due. Naloxone spray, the spraying of the thing. I think this is, a couple of tools which we didn't have 2 years ago and is now available to the population for opioids. The second issue we have is a major issue with what do we do with chronic pain. We have more and more and more people. We have an aging population. We have all kinds of disabilities. We have all kinds of things. And I, as a physician, was the recipient of lectures that were given to us in the 1980s as how we were opiophobic. Physicians were afraid to prescribe opioids. What's going on? We're not treating chronic pain properly. We don't know what we're doing. Opioids will be the solution. Well, as usual, the pendulum swung from A to B, and now we have this epidemic, going on with prescriptions. And I think there's two things. First of all, a major effort going on at the moment with educating the physicians. It will take some time to reverse the pendulum, but I think there are some signs that the pendulum will reverse. And the other thing also is that the pain, the treatment of chronic pain is not only opioids. Give somebody OxyContin and go treat yourself. The treatment of chronic pain is a comprehensive program involving a number of alternate methods. One of them is opioids. And by the way, opioids is now increasingly coming up as being not that effective, in fact, in the treatment of chronic pain. Two, the nature of the medication is that it will make you dependent when you use it after 3 to 6 months. The third component then is addiction, and I agree with my colleagues, but it's not the only one. In addiction, at the moment, there are new methods of delivery going on. One of the things that has been a problem for us is the non-compliance that people have. People are given medication, they don't take it. The same thing applies actually with schizophrenic patients. So learning from schizophrenia, increasingly the medication that will be provided will be in an injectable form. There are a number of medications that are here in the United States, but are not yet in Canada. I really would like the committee to make a recommendation about that. There's a medication called Vivitrol. The medication are implants, and in the future they're probably going to be vaccines. So there are a number of future things coming up, and for some reason we seem to be delaying its introduction in Canada, and I would recommend that we do something about that. Unfortunately, the methods of delivery of our medication change, but so is the method of delivery of drugs. And one of the things that's being singled out at the moment is the famous electronic cigarettes. The electronic cigarettes, the cartridge of electronic cigarettes, which was supposed to be, no problem and all that kind of stuff, can actually be used for a number of things, including the delivery of opiates, including the delivery of your favorite drug, including a number of things, and we are really worried about that, again, as a new method of delivery. So in thanking the community, please put the crisis in perspective, and there is a number of components of it, and I think there are some possibilities. I wouldn't talk about solutions, because humanity has experienced addiction since its beginning, but certainly to reduce the harms of reduction of the present epidemic is possibility, and it's opening opportunities too. Thank you.
Thank you very much. Now we're going to go to our 7-minute round of questions, and I'm going to keep it right at 7 minutes. I usually leave a little flexibility, but I'm going to keep it at 7 minutes because we will be restricted with the vote coming up. So we're going to start this morning with Mr. Kung.
First of all, I'd like to thank all the witnesses, for your insight on the crisis we are all facing today. And my question is to Ezra Day or Carol Hopkins. In Alberta, 3 bands of the Stoney Nakoda reported in July this year that identified nearly 60% of their adult population were struggling with opioid addiction. In 2015, the Blood Tribe also declared a state of emergency on this issue. What factors do Indigenous Canadians face which increases their likelihood of suffering from opioid addiction? That's question 1.
So I'll answer part of that, and I'll turn it over to Carol. But this is really an issue of access, and you have to look at the history of opioid addiction in our First Nation communities. You look at First Nations Inuit Health Branch and the drug program. When I was a chief for a Serpent River First Nation for 10 years, we used to get the drug reports, and the 2 main drugs that were actually administered in our community, the highest rates were methadone and opiates. And this is really a systemic issue, and the roots are because this is how the medical profession was dealing with the health issues in our communities. They would give opiates as a way to deal with the health issues and concerns of our people. And this would then establish not only the culture, but a really deep dependence on opiates. So, I'm gonna just suggest here very quickly that we have to analyze this problem from a systems and a systemic perspective, in that this is a shared responsibility. It's not only the individual, but the federal government needs to really examine, where they're at fault here. The federal government is to blame for a large portion of the problems that we're faced with. Our people will have to deal with this as individuals, as families, as communities, but this is a real systemic and chronic issue that the genesis is found in the programs that are governed by the federal government. Carol?
Yes, I'd like to.
And there, like you're saying, you're pointing fingers at the federal government. So what are those faults, like, we should be looking at, instead of saying it's a shared responsibility. And we would like to know, what are those, faults on the federal government side.
Yes. So basically, there are no alternatives. Many of our people they don't have the types of psychosocial programming or access to ways to deal with the historical trauma or physical pain. The reality is this is an investment spending opportunity, and as my colleague had indicated, this is a crisis, but it's also an opportunity. And I think when it all boils down to it, there's a two-tiered health system in this country. First Nations do not have the level of health that mainstream Canada do. The stats are there. We know that there's a gap that exists. I think it's leveling the playing field. When our First Nations have access to appropriate health programs and services, when we actually achieve health equity in this country, First Nations will be able to deal with this issue.
Yeah, as I said earlier, and as you heard from my friend Dr. Claudette Chase, that the primary healthcare system that we have in First Nations communities is at the nursing station. And nurses employed by Health Canada do not have the scope of practice to engage in supporting First Nations people in their own community in addressing opiate issues beyond 30 days. That's one point. The second point is that we don't have access to treatment for opiate addiction. And when there is access, it's short term. Without access to treatment, many people are suffering in their communities, which leads to illicit drug use. Okay. And the problem continues. And I'm thankful that you mentioned Southern Alberta, because I also want to say that the research on addiction says that it's permanent brain damage and it can't be undone. And I think that that's a racist way of keeping people on methadone, because people in Indigenous communities have had to leave their communities to access treatment, and the primary course of treatment has been with methadone by physicians who say it's a course of treatment for the rest of your life.
Thank you. So you touched a little bit on naloxone. To your knowledge, do all First Nations communities have access to naloxone to treat opioid overdose? And also another one, and have there been any difference in how this crisis has been felt by the urban versus rural population? What are the differences or similarities when facing this crisis? So those two questions.
So access to buprenorphine naloxone has been a challenge for First Nations communities. We have been successful in getting some greater access to buprenorphine naloxone. It's by exception on the non-insured health benefits, and then in provinces like Ontario, the Minister of Health has just announced greater access. The program that Dr. Chase is talking about is successful because it uses buprenorphine naloxone. And so I would encourage that buprenorphine naloxone has to be the first line of treatment for Indigenous populations with an opiate addiction, because it allows them to stay in their community, and it allows for a team-based approach. And Health Canada has to change its policies around nursing in communities so that it's a strength-based primary care program and not a nurse program, so that they can work with others in communities. The other question you had, I'm not sure that I answered. The naloxone kits are not widely available, that's true. We need greater access to naloxone, and we need support for broader distribution to high-risk populations for naloxone.
No, time's up. Dr. Carey.
Witnesses for being here today. I think we could probably spend a lot more time to get your input, and maybe that's something we can look at. But I wanted to ask a couple specifics, because we're all looking for solutions. And I know a few years ago, you may know Alvin Fiddler, who was the Deputy Grand Chief of the Nishnawbe Aski Nation. And he was pushing with Deb Matthews, the minister in Ontario, to make opioids the entire class tamper resistance, because one of the things that was problematic, I guess, in First Nations, Ms. Matthews even said in one community in Northern Ontario, it was 85% of the community was addicted to opioids. And I guess, Dr. Chase, you were saying they get this generic Oxycontin, they crush it, they snort it, they inject it, and it's very problematic. So, you know, I was wondering if making that class of drugs, the entire class, tamper resistance, if you still support that idea, but also how much money is allocated to mental health and addiction in First Nations, and what services are offered with that money? I was wondering if you could answer that. So 2 questions there.
I'll speak first to the tamper resistant. I think they don't work. People who are addicted are in tremendous physical, emotional, mental pain, and that motivates them to get around all those tamper-resistant things. So while that may slow some things down from becoming injected, it doesn't stop them from being abused. And I'll let the others speak to the actual amount that's allotted, but I can say at the community level in Yabmatung, the community has taken money from other projects so that they can pay a Master's of Social Work to come in and offer counseling. There is one drug and addictions worker in a community where a survey 5 years ago found 400 people openly admitting that they had an opiate addiction. So one worker, and then there are 3 mental health workers with various levels of training and ability that are from the community and that work with people in the program. The program does get funding from Health Canada, and this is at the higher end of the spectrum of them being helpful. The program was on an annual basis, so the people who were within the program were using their energy every year to write a new proposal. I heard from a mole within Health Canada that the advice was to fund these programs at approximately 60%. I can't swear by that, but I think that was accurate information. So here you have a program that's underfunded, understaffed. We have people on the waiting list that want to join our program. We don't have enough staff to do the direct administration of the Suboxone. So whatever the funding's at, it's not adequate to truly fund a community-based treatment program. That there's the trickle-down thing, Pakanjikum, which I'm sure as a First Nations most of you have heard about, where there's a huge housing crisis. And I don't know how many new houses they get a year, but there's never been someone who came in and said, this is how many houses you need, we're going to build them this year. Because we know this is why you still have tuberculosis, rheumatic fever, all these things. I think the same thing with the addictions treatment. Mm-hmm. We know how many people are addicted. The communities are aware. They know what they need. Let's fund it adequately. Let's admit it's got to be 5-year funding at the very least. And let's start saving some lives.
Well, that I think, we've heard that prevention is one of the best ways, and I believe it may have been that chief, I don't remember who it was, so to attribute the quote, but the quote was, the drug pushers in my community wear white jackets. And I think he was referring, we've had witnesses to say how physicians have a role here, and Chief Day mentioned, the program. It seems to be the simple thing is to give out the opioid instead of looking at these long-term treatments. So I was wondering about the whole idea of proper prescribing, but again, if you guys had to lay out a solution and give us some concrete recommendations that the federal government needs to do differently in regards to opioid abuse, we're looking for your advice. What would that be? So I can
only speak to my practice, which includes the physicians that serve the Sioux Lookout Zone, and our practice of prescribing is very cautious. When we do prescribe opiates, it's often because There is very little funding for physiotherapy, for occupational therapy. People get injured at work, and we have no access to those services. So the basic services that would help some pain that is acute from becoming chronic doesn't happen. We do have some challenges, but increasingly in Thunder Bay and Winnipeg, specialists are no longer sending home orthopedic patients with 200 Percocets for a procedure where it might be required that they take them for a week. We are very cautious in our prescribing practices, and I appreciate you bringing that up. I absolutely own that it was physicians that started this. It was our prescribing practices in Ontario that started this. But often it's because we don't have other services. So getting physio, getting OT, getting massage therapy, getting chiropractors into these communities would decrease the need for many of my arthritic patients whom I'm obligated to provide.
If I could get some comments from the others too,
Sure,
because
sorry.
basically, like I'm a chiropractor,
Yeah.
and 70% of these opioids are given for back pain because there's no other services that are out there. But if I could get comments, I see Dr. Galbi and Chief Day and Carol, everybody wants to.
Just very briefly, I just want to make sure that we do not go into a knee-jerk reaction of suddenly moving around and say, okay, well, no more opiates. Unfortunately, I have an impression that part of the fentanyl crisis that has occurred has been in people suddenly getting desperate because suddenly the medication was cut down. We're talking about a progressive reduction with the emphasis on progressive reduction and the progressive reduction with substitution also of alternate method. And I sympathize with Dr. Chase. If you have nothing else to play with, then it's kind of difficult to look for alternatives, but we really have to have a systematic approach to funding those alternatives and making them available too.
Yes, thank you. I'll be very quick here. Let me talk about the 30,000-foot solution. It really is about health transformation and looking at First Nation jurisdiction on health. That's where we need to be, because essentially jurisdiction means authority, authority means responsibility. We've not had a history of having our ability to respond to our own issues being respected. So for example, we look at the Indian Act system. The Indian Act system is really at the root of much of the oppression and outside impositions that have affected the daily lives of First Nation people on land, the people, and our economies. So that's the first piece. And if you think for a second, what transpired here in the last several decades. The last 2 decades, we've seen 2 significant studies take place. One was the Truth and Reconciliation Commission. The other one was the Royal Commission on Aboriginal People. Those 2 provide the guideposts that are needed. One on an institutional self-determination level, which really talks about the imposition of the Indian Act. Those are things that talk about nationhood and the overall community. The other one is the TRC with the 94 calls for action. All the solutions are in there. So that's the 30,000 foot. You know, the issue here was looked at by the First Nations in Ontario. A few years back, we took the approach of studying this, and we did take a stand approach, and the report looked at 4 strategy areas that are addressing prescription drug addiction. The first one is obviously looking at prevention and health promotion. 2 is looking at healthy relationships at all levels to address complex issues, because this is a very complex issue. It involves everybody being part of the solution. 3, reducing the supply, and I think this incremental approach to disentrenchment of this insidious addiction is really where we need to go. And the need for a continuum of care. And that continuum of care being here, again, First Nations being responsible and being responsive and being respected within that process. You know, overall, this is going to require the investment that is needed to address the issue. The problem that we're looking at right now with respect to the joint review on the non-insured health benefits in Canada for First Nations is the fact that historically the program is not a needs-based program. It's based on funding levels. The allocation that comes down from Treasury Board, not so much looking at the cost to deal with the solution. So again, throwing good money after bad and not really addressing the root of it and eradicating terrible issues like the opiate addiction. The committee, we do need investment spending. This is the only way.
Okay, Mr. Davies.
Thank you, Mr. Chairman. Thank you to all of you for being here today. It's very compelling and helpful testimony. The first thing I want to establish is a benchmark. Dr. El Guabali, I'm not sure if I pronounced his name properly. I think you made the excellent point that in many ways these issues have been with us for a long time. The substances change, but the causes remain the same. The challenges are the same. The lack of activity and action remains the same. But my first question is I want to just briefly get each of you to tell me, in your experience, are the rates of addiction going up, down, or staying about the same in your experience? Ms. Hopkins?
Addictions continues to be one of the #1 issues noted by First Nations people. In the First Nations Regional Longitudinal Health Survey, First Nations people at 82% across this country said that substance use is the #1 barrier to wellness in First Nations communities. That might not seem surprising, but it is surprising when it's 82% saying addictions is the #1 issue before housing, before employment. And so First Nations communities have been struggling with addressing substance use issues in their communities for a long time, but again, on outdated formulas, not based on needs. And so some communities receive funding based on per capita, which doesn't even, okay.
I have a number of questions.
Okay.
I'm just trying to find out, is it getting worse or better? I know it's profoundly important.
We are seeing success with programs that are currently available, but is it meeting the need? No.
Okay. Chief Day, are you finding addiction is it becoming a greater problem, lesser problem, or as bad as it always has been?
I think you have to look at addictions as a systems issue. And I think we can look at the numbers and we can certainly generate the stats, but this is a very complex issue. So, for example, the cost impact of alcoholism or marijuana misuse is, in some cases, and I don't like to use the comparison because it's all bad, but when you talk about fentanyl and when you talk about the type of opiates that are wreaking havoc in our communities, the cost is enormous. And I would also suggest that there may be a need to start drawing some correlations between poverty, nutrition, diabetes, and addiction. If we've got elevating rates of diabetes, chances are we're going to have elevated rates of addiction as well. So just my comment.
Noticing is addiction getting more prevalent or less?
I've been in the area of Sioux Lookout since 1982 when I first went as an outpost nurse. And when I first arrived, alcoholism was a bigger problem. I think the introduction of OxyContin, which many of my patients said it was the first time in their lives they remembered feeling relaxed and not anxious. I mean, it was, you all know the story, it was engineered to have that impact. So I would say there were more people involved than there ever were with alcohol. And I would say the rates are going up and the users are getting younger. So we've seen 12-year-olds and 14-year-olds injecting in some of the communities. So the numbers appear higher to me, but part of the challenge is the numbers aren't there, but I would reiterate the point, this is a complex systems issue. And we need that.
I'm going to take about general population surveys, and general population also, sometimes the figures come from the states. At this point in time, looking at the last 20 years, the rates for alcohol are about, so the answer to you is go drug by drug. The rates of alcohol are more or less steady, maybe slightly decreased, but really steady. An interesting phenomenon among final grades of school is that as we are very proud of the fact that we've reduced the rates of tobacco use, which has really come down, well, marijuana has gone up. So that's really the craziest of it. Opioid, I think, is a more episodic phenomenon, and actually I don't think we have 20-year studies on that. And at this point in time, it's been on a high, particularly for the overdoses and so forth. So.
Thank you. The reason I ask is I think in some ways when we look at a study like this, we're talking about water being wet. We know it's complex. We know there's incredible social determinants involved: poverty, lack of housing, lack of employment, impact of colonization, if we're talking about First Nations, trauma, lack of treatment facilities, regional differences, the fact that our healthcare system does not pay for physiotherapy, chiropractor, counseling. You know, you can go to a doctor if you're sick and you can get a prescription for a pill and go get that paid for. But if you are directed to a psychologist, you can't go get 3 or 4 sessions, which may be a more appropriate angle of care. So we, and by the way, I know at the AFN in Ottawa in 2011, a resolution was passed to support the Mohawk Council of Akwesasne's declaration of a state of crisis due to the community's alarming rate of substance abuse. It urged the federal and provincial governments to identify funds and resources for community-based programming and services 5 years ago. In 2012, the AFN Special Chiefs Assembly directed the National Chief and the Executive Committee to urge the federal government to develop and fund a First Nations opiate recovery and prevention strategy. That's 2012, that's 4 years ago. We have been calling for these programs and responses for years. It just doesn't happen. So my last question to you is going to be to give each of you an opportunity to follow up on Dr. Carey's question. To get a real solution, what is a suggestion you have that the federal government should take? If you were the Minister of Health or the Minister of Aboriginal Affairs or the Prime Minister, what would you be directing right now to help us deal with addictions, opioids and otherwise in this country, in First Nations communities and otherwise?
I would suggest that the federal government seriously look at the resources to fully implement the First Nations Mental Wellness Continuum Framework. It addresses the lifespan. It has a core basket of services that are required. Neonatal abstinence has grown 4 times the rate. First Nations schools have now classrooms full of children who were born on methadone. We don't know the long-term impacts of methadone in utero from infant, toddler, early childhood development. We don't know what those long-term impacts are, but we have classrooms full of kids who are struggling with that. Senior population with chronic health issues and substance use issues. This mental wellness continuum framework is a model that is intended to address that, and it relies on Indigenous culture, Indigenous governance over those services. And we need the resources to implement this. We keep developing these frameworks, but we don't have resources to implement them.
Time's up, Mr. Davies.
Yes, I think this is going to require that we don't just do a committee report. I think there needs to be the commissioning of an opiate crisis response strategy for Canada, and that would include the engineering of a meaningful, shared, and effective national response to opiate addiction and the crisis. Because in Ontario, for example, we do have the Taking a Stand strategy, but it doesn't have all the jurisdictions around the table, investing in a shared solution and response. And that will include the individual, it'll include the families, and it'll certainly include First Nation jurisdictions. So I think we need to step it up. It needs to be commissioned, and it needs to be funded appropriately.
Okay, moving right along, Mr. Oliver.
Thank you very much, and thank you for your testimony today. As you're aware, we've been studying the opioid crisis across Canada, and Claudette, to your concern, I think our goal as a committee is to bring some concrete recommendations forward to the Minister, to Parliament, to Health Canada to address the crisis. What I've heard is that the opioid crisis in Canada is absolutely magnified in First Nation communities, both in terms of rate of use and also with lack of treatment. The frame I've been using for this, which came from one of our earlier sort of presenters or testimony, is that we need to move from a specialized model of addiction treatment to primary care. We need to have primary care physicians, nurses providing treatment. We need nationally agreed to evidence-based treatment plans so that we all are using the same frame and are moving forward for treatment. There has to be far better access to treatment programs, both from ER referrals and from safe consumption site referrals, so that people are getting follow-up, not just left in that state of addiction. And there has to be dramatic increase, and this is one where I want to come back to, a dramatic increase in funding directed to treatment centers, not filtered through a mental health frame, but direct to those treatment centers. So when I've heard listening to your testimony, I'm looking for specific recommendations to deal with First Nation communities. So what I heard was
that northern communities in particular, it's very, very difficult to get treatment programs and centers based in those northern communities. That it's, I think the terminology was land-based. Does that mean services right in those communities, or does that mean we don't want to fly people out for treatment, right?
Right.
We want the treatment services there. The second that I heard was there's significant problems with Health Canada program restrictions, particularly around scope of practice for RNs and I would almost artificial time limits in terms of what the service limitations they can provide. That was the second thing I heard. The third was an over-reliance in First Nations on pilot funding and year-by-year funding so that you can't get these programs established and funded and get permanent staff recruited. Really hard to recruit people in Southern Ontario on year-to-year contracts, let alone in Northern Ontario or Northern Canada communities. And the third was healthcare worker burnout, the fact that there doesn't seem to be adequate training, adequate consultation services for the healthcare workers, and they burn out much more rapidly in northern communities. Is there anything else? First of all, is that a fair summary? Those four things differentiating a little bit in First Nations, without getting into root cause, without getting into why.
To clarify, it's not just a Northern Canada issue.
Okay.
It's First Nations, Indigenous communities. So while in northern and remote and isolated communities, we have transportation issues and access to stabilized health human resources. The opioid crisis is not just in remote, isolated communities, however. The example being Southern Alberta. In every First Nations community that is dealing with an opioid crisis,
centers, the others I meant to refer generally to all the First Nations. Are there, besides those four, are there any others that you would add to the list that would add to the complexity of treatment in First Nations?
Yes, I think integration, aftercare, I think it's really important to recognize that one of the bigger complex issues is poverty and often how people get involved in addictions. For example,
sorry, Isidore, I have 7 minutes, so I totally get there's the mental wellness framework. I actually wanted to come back and ask you a question.
Housing and social income.
Yes.
That's a very important piece. Is that the basic needs.
So my question on that is, how would you, if we were going to give specific, what we heard from a physician is that we need to right now to end this crisis and deal effectively with the people that are suffering from quite significant addictions and overdose and death. We need to direct funding directly at the treatment programs, not through the mental health sort of lens that sort of filters the money and not all, and limited funding seems to trickle through to the treatment programs. So given that there is the First Nations mental wellness continuum, and I totally understand that, is your priority to fund that right now or to direct it to, let's get the money into the treatment centers? What would your, if you had to?
We need both.
You need both.
We definitely need both. This continuum, the work has been done. We have the capability, we have the experts in our communities. We need both treatment and we need to fund the continuum.
Could I just speak? I don't think that it's a problem getting the program started in the community. I have been humbled by the skill set at the local level. The support isn't there. One very specific thing that I think could be done to decrease mortality is the nursing stations are allowed to give out safer injection kits between the hours of 8 and 5. And I think naloxone should be included in those kits.
Okay, thank you for that. Any other recommendations around treatment?
What I just want to mention is that there is a crisis right now, and I think there is short-term solutions, the long-term solutions. I mean, the certainly should be the short terms is, naloxone. People are dying every day. Something has to be done about this. But then that gives us an opportunity to think also long-term. One of the things we've done, I think, is that we're not satisfied with the way services are delivered, in our country. I'm sure it's better than others, but we take an international perspective. And I'm humbled by the fact that I cannot think of any country that has found a magical solution, including countries like the Scandinavian countries that are supposedly providing more of a social cushion, than ours. And when you go there, opioids is there and everything else is there. So it's really a humbling a harmless experience. But for me, it would be overdose, longer-term education of physicians. I think this is going to be, and health professionals, by the way, they're not only physicians. And looking then also about what's evidence-based and so forth, because all we're providing right now is not evidence-based, I've got to admit.
Big Pharma. So the prescription practices of physicians seems to be at the following through on advice and direction and training from pharma on the use of opioids. Do you have any thoughts or comments on the role and responsibility of pharma in this crisis?
They need to be held accountable for the education that they provide, and we've seen that history with Purdue Pharma. Specifically on the misinformation they provided to prescribers related to the issues of OxyContin. The only other one I would add to your list now that I have the mic on is harm reduction. we need more education on harm reduction, and I want to recognize Minister Philpott's championing harm reduction in international conversations, and we need to apply that at home. We need much more education, investment, and resources to support harm reduction.
Okay,
One example of big pharma. One example of big pharma was the tamper-proof thing, and when I saw this was brought up, you know, I remember resigning actually from the committee that recommended that. That was a joke. All our patients put it in boiling water, and that was the end of the tamper-proof. So now. Thanks.
Okay, that ends our 7-minute round. Now we're going to go to 5-minute rounds. We're going to start with Mr. Weber.
Thank you, Mr. Chair. My first question to Dr. Nadi El-Gabali. Doctor, you mentioned in your presentation experimenters, the one-timers, the young kids that go to rave parties and maybe experiment with an ecstasy or marijuana that in a number of cases have fentanyl laced in these things, causing them to either die or end up in emergency. Now, I've been doing a bit of a reading with respect to the testing of these drugs and access to tests that these kids or these individuals who are taking these drugs to test to see whether or not there's fentanyl in a particular drug or not, or if it's laced in a marijuana bag. Are you familiar with these test strips at all, Doctor, or the way they work, or if they even do work?
I guess I have some difficulty. First of all, I guess what I wanted to do is to differentiate the lethality that we're seeing right now from addiction. Not all the kids that are dying today are addicted. Sometimes it's the first, second, or third time that's there. They also were looking for something else that turned out to be laced with whatever that goes on. Now we've got the strips. I am unaware that somebody will start doing a test strip, as you take the material that's being given to you, that suddenly the kid is going to go, and I don't know why I call kid when all kinds of people take it, but still go and test the product, that goes on. So I'm not that encouraged, by that kind of thing.
Okay, I'm just concerned because the Liberal government, of course, is looking at legalizing marijuana in the future here, and of course it'll be in abundance in society. And with the problems now with fentanyl-laced marijuana, we're going to be seeing a lot more of this, and so I think that we do need to look at ways of testing these drugs before they get into.
By the way, Mr. Weber, as you know, I was in an international conference in Montreal last week, and so was Dr. Chase. And I think the wisdom at the moment is that our recommendation for physicians is to go through this phase of decriminalization, which is urgently needed, and then the next step being legalization. We are worried as physicians to move from criminalization to legalization without going through the step of decriminalization, for whatever. Yeah.
Great, thank you. I'd like to just talk to our First Nation representatives here today with respect to education. That's a bit of my background for politics. With respect to the way or how you are educating your young or your community, what do you do to reach your populations, to educate them, to warn them of the risks involved? Are there settings in your classrooms, or do you constantly scare them of the fact that this is dangerous and they should not be experimenting? Just maybe talk a little bit about the education of your First Nation children.
We've developed a early intervention program. It's called Buffalo Riders, and it educates primarily grade 7 and 8 children at risk for substance use. But in every community, and we've implemented this program in a number of First Nations communities, they have found the curriculum to be so beneficial that they've used it not just with kids at risk, but to educate grade 7 and 8, even grade 9, and their parents about risks related to substance use issues. And it's been a program that has met every province and territory's standards for health curriculum. And so schools in communities have implemented this. Again, one of the issues is not enough resources to expand it. Thunderbird Partnership Foundation has a mandate to serve all of Canada, and I have 8 staff. So, and we are, developing a model of train the trainer to expand the capacity to deliver this early intervention program, but it's had good results in terms of reducing substance use. It's been used as an alternative justice measure as well, so it's had good success.
Interesting.
Yeah, I'll take a different approach, and I look at this issue of the legalization of marijuana and recreational use. There's a very important process that's underway in Canada right now, and it's examining the regulatory landscape on marijuana use. And I think it will be critical that First Nations are directly involved, that we're participating in that, because the situation as it unfolds in terms of access to marijuana in our communities, it's going to have a very interesting, complex, and sometimes an insidious impact. And I think that my point being is that we all need to be involved. There's a shared solution approach that's needed. And if we get in on the ground floor with something like the regulatory landscape on the recreational use of marijuana and the decriminalization of marijuana, then certainly our First Nation communities will have to be involved in a very widespread education on these issues.
Time's up. Mr. Ayoub.
Merci, Monsieur le Président. If you may just put your hearings, because French for some question I've got for you. Entendre.
As I listen to your comments and as I read about the opioid crisis, especially what's happening in Sioux Lookout, I'm quite overtaken by emotion, and I'm not making light of this. We're talking about naloxone as a fast treatment to save a life in the moment of crisis. It's a short-term solution. What I'm interested in, because the Sioux Lookout case, if I may call it this, is nothing new. It hasn't been happening a week or 2 weeks or a month. We're going back to studies that go back to 2013 and before. What I'm interested in knowing are the causes, because having a plan, we need a short-term plan to save lives today, but it takes a long-term plan in order to change things and not to come back in 5 years' time or 2 years' time and encounter the same problems. So I'd like to know what you have to say. Whoever has an opinion to express is what your plan is in the medium and long term, and what do you expect, what has been done previously which did not work, and what should work. And yes, you have to consult amongst yourselves, but we also think that we need to change things and not do the same things in the past that didn't work previously. So I'd like to know what you have to say about that, and understand that 5 minutes isn't very much. It's a very short period of time. But I'd like to hear you about this matter. Thank you.
The answer among the panel is that this framework talks about the paradigm shifts that are necessary to implement this. And so it's systems change. And one of them is, in the background color of this model is what they call PEI red. And it's the color to represent culture. And so one of the significant changes that we need to make is to shift from an evidence base absent of Indigenous knowledge and cultural practices to the inclusion of Indigenous knowledge and cultural practices. That has not been consistently part of our answer in addressing any issues in First Nations communities because it's not recognized as credible evidence. But we do have evidence now that says culture makes a difference. And in fact, in the center of this framework, it talks about 4 outcome measures: hope, belonging, meaning, and purpose. And there's 13 measurable indicators. And we have the instrument to measure that and to demonstrate the impact that culture makes. But again, we need capacity to be able to help communities use instruments to collect data and to demonstrate change that they make, both for individuals but overall community wellness. So shifting from evidence absent to inclusive.
Avez-vous eu l'occasion d'avoir des résultats?
Have you had an opportunity to see any results through these methods, to implement and to see that there are effective results so that they be recognized, so that we can implement this and continue to implement these programs in the future?
For 13 years, and in that time, we had 100% of the youth completing the program. Nationally, in any program, mainstream or First Nations, the outcome was 50%. And not only did they complete their course of treatment, they also returned to school at a rate increase of 40%. So 40% coming into treatment, 40% more return to school post-treatment. 86% of youth discontinued sniffing gas and solvent abuse post-treatment. And the reason that they did was because of the access to culture. And their common statement to us was, why did my life have to end up in such turmoil before I had access to culture? That's just a little insight. With the Native Wellness Assessment, we're seeing that there's an increase of at least 30% from a whole person perspective, meaning 30% increase in having hope in their life, knowing where they belong, having a sense of meaning, and having a sense of purpose in their life through the use of cultural practices.
Thank you.
Time's up, and I need unanimous consent to continue on. The bells are ringing. How much time do we have? You know?
Isabel, I think it's just the opening department right now.
Oh, it's the opening?
We got to get the routine
Okay.
Yeah.
Okay, we'll continue on then. Mr. Ritz, welcome to our committee. You're up. 5 minutes.
Thank you, Mr. Chair. Thank you, ladies and gentlemen. Tremendous knowledge that you possess, and you have some of the answers in front of you. I guess the problem is, how do we coordinate all of that and actually have a footprint that means something? A lot of what Mr. Al-Gabali was saying, we're pushing a bubble through society here. It started with, before there was always, like you said, there's always been addictions throughout history. But you talked with heroin and alcohol, now it's designer drugs. How do we ever get ahead of that bubble and start to make a real difference? What's it going to take? I know funding is a big part of it, but how do we actually put that money on target to see results that then draw more funding? That's the key with government funding, is to show those early results, to start building on those successes. And Ms. Hopkins, you talked about some successes that you've had. How do we actually get that message out?
We've demonstrated the results.
That I'm unaware of a prevention program that has been tremendously successful. And when I hear the proponents...
I understand. There's no magic bullet.
There is no magic bullet. And I think at the moment some of the programs that provide the best data is, first of all, 2 levels of prevention. The primary prevention for everybody in the schools, for example, as being, something that's there. And then the second level for people we identify at risk. And for example, that starts with children whose parents are already, using drugs.
Right.
And my personal preference would be to start with the people at risk as being, I think, a good prevention program. But I don't have a magic prevention program.
Ms. Hopkins?
I was saying earlier that there have been a number of pilot programs that have been tested and have demonstrated good evidence, but there's never been any continuity to those programs, or that the investment in those programs have, like I said earlier, have been short-term. So we do have the demonstration, we do have the evidence. There's a number of journal articles, if that's the type of evidence that you're looking for, or that is necessary, that speak to the success of Sioux Lookout, Northern Ontario types of programs. We have the programs from the Drug Utilization Prevention and Promotion Program that didn't, get sustained long term. The youth treatment programs the residential treatment programs who do also have good data but have limited resources to make the difference that they could. For example, with that network of resource, they could be a part of the solution in supporting youth when they go home if there were added resources for web-based mental health services. Okay. Yep. Or social media-based services. We don't have that capacity right now to reach youth. We have the implementation of a brand new helpline, which is fantastic, but it's not enough. We still need to keep going. So
a lot of it is the continuity of.
Continuity.
I understand your concern with project by project, year by year funding. You never do get that critical mass that lets you start to roll towards the finish line to show that you can actually do that. And I think one of the things that I think it was Chief Day mentioned, the aftercare care, and how important that is to maintain that continuum. How do you see that rolling out? This would be done on site, that combination of elders and mentors and community based aftercare care along with professionals that.
It's all of the above, and I think that getting broad, we have the solutions already. Mm-hmm. Like it's all here. I think there's a social contract that is required in this country. This addiction, it affects everybody, and it's Certainly. Not just in the remotes; it's everywhere. But we need to get to the point of a new configuration of shared responsibility, matched with investment spending that is innovated to address the issues today. That hasn't happened yet. We're still passing the buck. We're still looking for data. We're still looking for solutions and approaches. But we need to approach this from a shared responsibility perspective. And I think that's incumbent upon this committee to say, you know what, let's get everybody at the table at the same time. Let's reconfigure a shared responsibility and put the investment to it.
There's also some gaps and overlaps when you look at on reserve is federal, and then off reserve, there's people slide into the social services at the provincial level, and of course there's a lot of cracks to fall through in between that. How do we streamline that operation as well so that those cracks shrink and people then
that's where First Nations come in. We are the experts. We understand the landscape of the multi-jurisdictional overlaps on primary health care, on policy. We've got the ability to do that. I think we need to be involved in the solutions, and we need to be there at the table to help configure the solutions.
I just wanted to speak to the fact that we have the evidence of prevention in this room with good nutrition, good education, solid housing, and an overall sense of well-being, which we have deliberately, as the dominant culture, not allowed in our First Nations and our Indigenous peoples in Canada. So I think the evidence for prevention is strong before us all. And we just need to acknowledge it and support what my colleagues have talked about of a new social contract.
Time's up, Mr. Ritz.
The evidence I have, which I would like to add, is that taking the kids out of their culture and sending them somewhere by playing somewhere else is an utter disaster. And unfortunately, I've seen Health Canada doing that several times. When there's a crisis, take kids, send them somewhere else. We've had this experience in Calgary, where people from the northern communities coming around. I'm not too sure what the recovery rate of that was, but I think it was very close to zero. So establishing program within the people community is critical.
Thank you very much, Dr. Elson.
Well, thank you all very much for coming. Valuable input. I'd just like to, and I apologize, I had to step out for a moment. I understand that sort of on a slightly unrelated note, there's an implication that the legalization of marijuana might lead to an increase of laced fentanyl, or marijuana laced with fentanyl. From what I understand, part of the purpose of the legalization is that you have a legalized, regulated, and inspected supply chain that would in fact prevent this, because this was one of the reasons for legalizing it. So this is when you're buying it from a legal source, you don't have that problem. I just wanted to clarify that this was behind this strategy. Now, back onto what we were talking about before, there was a couple of different physician groups, College of Family Physicians and Indigenous Physician Association of Canada. There was a a guide, and I'll quote the title of it, The Health and Healthcare Implications of Systemic Racism on Indigenous Peoples in Canada. This was released in 2016. It noted that there was unintentional racism, and it would manifest in the way of erroneous assumptions. Again, having been in the healthcare system for 20 years, I'd say not all of it was unintentional. But it said that these assumptions would change how healthcare providers, all the way from first responders up through nurses and physicians, might affect care. Ms. Hopkins and Mr. Day, in your experience, has this kind of racism in the healthcare system affected how victims of addiction are treated?
Well, I'd like to go back to my earlier comments related to methadone.
Mm-hmm.
So we've had significant issues related to methadone clinics, mm-hmm. And risk to First Nations communities. And so methadone providers, and I believe in methadone, it's an absolutely necessary mm-hmm. part of the solution. But when the solution is absent of and disrespectful of First Nations governance, who then have to carry the burden of the risks related to methadone in community, that's to me racism, as well as telling First Nations people that once you are on methadone, you're on methadone for the rest of your life, meaning you can no longer go home anymore. You can't take your new children to meet their grandparents in the isolated remote community, that you have to live in an urban environment in poverty outside of a family system of support. That's racism. We have seen evidence where First Nations people have been moved from methadone to Suboxone to being opiate replacement therapy free and living well in their communities. The connection to land, connection to people, and connection to their lineage and their language is critical for their overall wellness. And so I offer that as an example.
Yes, I'll be very quick on this.
Sure.
We recently met last week with about 40 to 50 service providers, whether it be dental, vision, rheumatology, and what we were doing, sir, was we were asking questions about, providing service to First Nations under the non-insured health benefits program right now. What are the problems? Every one of them were experiencing all the same things. They were saying we want to treat the issue, we want to deliver solutions, but we can't, because there's constraints, there's policy guidelines that are based on the Indian Act system, which are very much at the root of the problem. It's because this is a race-based program, and basically what we're finding is that the situation and the impacts are exacerbated by racism at the institutional level within the funded program of non-insured health benefits. So the joint review right now is critical, and I think the committee should take a very close look at the outcomes there and deal with racism at the source.
Okay, thank you. Now, I went to medical school in the early 1990s, and there was some training that we had in, population-specific health, and much of it for First Nations people. I went to medical school in Winnipeg, which, as you know, has a large First Nations population. Do you find that there's any improvement in the training of healthcare providers to have more awareness to the particular challenges of our First Nations people?
I think there's interest.
Mm-hmm.
Certainly there's a great movement in cultural competency training, but do we have measures to demonstrate the impact of cultural competency and client outcomes? We don't have that data currently. I know there's greater interest amongst the College of Physicians and the family physicians to ensure that physicians have appropriate training in addictions, but also in understanding how to provide trauma-informed care to First Nations populations. We don't know what the outcome of that is yet.
All right, thank you.
Time's up. Mr. Davies, 3 minutes.
Thank you. Dr. Chase, in an article that was published recently, you described a program that takes patients out on the land as part of their treatment. And to quote you, said, "There are very few things I've been involved with in my medical career that I can say have made as much difference as this program. It is really very impressive." Can you expand a little bit on that program and how you think it may help?
Well, I mentioned that Yabmatung has a program and it's evolved over, we started it in 2010 in response to the state of emergency, and it has evolved, and whenever there is funding, people are taken out with elders involved. They go out by canoe, by motorboat, they get back in touch with their culture. And one of the first minor successes that we had in the program was I had someone say to me, for the first time in 3 years, my wife and I went out and got wood. And that may sound simple to you, it wasn't just a trip to get fuel. It was a day out on the land. They laughed together, they worked together. They came back feeling really proud that they got it. It was a spiritual connection that I am not Anishinaabe, I don't fully understand, but I could witness it. And I think that's where the successes come. Sandy Lake also had a program. They took people out for 2 weeks and they were abstinent for 2 weeks. And they felt great at the end of the 2 weeks. But when they went back to their community where there was so much around and no real ongoing support, they all relapsed. There was 100% relapse.
Chief Day, on October 1, 2013, BC's First Nations Health Authority assumed the programs, services, and responsibilities that were formerly handled by Health Canada as a result of the British Columbia Tripartite Agreement on First Nations Health Governance. Has this transfer or type of transfer of authority helped to support improved health and well-being for Indigenous people and communities in that province? Is that kind of a model that you would suggest to us might help in this transferring of authority to First Nations communities?
Yes, sir. Thank you, Mr. Davies. It certainly is the direction that we're going in. And last week we met with the health ministers. We were at the table, the Indigenous communities, and representing the Assembly of First Nations. What we've put forward is the First Nation Health Transformation Agenda that is going to be conjoined to the Health Accord discussions and the negotiations going forward. It essentially says, let's get First Nations into the process moving forward on First Nation health jurisdiction. And we know that the BC experience is happening in smaller isolated areas throughout Canada, where First Nations, once we have a place in configuring our solutions, once we have that authority, we then start to put forward the real cost of treatment, the real cost of prevention, and we get results. So certainly First Nation jurisdiction on health is key.
Well, we completed all our testimony right on time. The bells have just started to ring for the vote, so I want to thank the presenters for their answers and their concise responses to our questions. I want to thank the members for their questions too. And Dr. Chase, you said you hope this doesn't fall on deaf ears. I'm not sure exactly the way you expressed it at the beginning, but you've added a very unique perspective to this debate for us, and it will be reflected in our committee report as strongly as we can present it. So I want to thank you all for your presentations. They were excellent presentations. I'd love to see that little red wheel that you keep holding up. I'm going to go back and have a look at it. But anyway, thanks very much again, and thanks to committee members for being concise and on time. We're just finished perfect. So now there's a vote being called, so we're going to go do the vote, right?
Yep. You have 25 minutes.
Perfect. 29.
Yeah. So Thursday, committee business, we're